know, she doesn't need an introduction, and she's actually working at the moment at the Wits Donny Gordon Medical Center and assists with the training and teaching of undergraduate doctors. She's not only a person of interest with contraception, she's also a very important oncologist, having trained at the Hammersmith. So, Dr. Trudy Smith, adolescent contraception with thanks to Bayer. With me this afternoon is Professor Steve Jeffrey, and he's very happily going to thank you. And would you mind, Trudy, if people, as the questions arise, if you take them to keep them timeless and apposite, because many questions will come, and I'm sure that it's better to keep them coming as they arise than having a whole lot of questions and running out of time at the end. Would you mind that at all?
I don't mind any way you want to do it. It's fine. Sometimes it might be just easier at the end, but it's up to you.
Okay, thank you very much. Steve?
Yeah, thank you. And yeah, we look forward to a very important topic. You know, often we don't know what to do with these, and there's often some finer, more ethical type issues to deal with as well along the way. So yeah, we look forward to hearing you on this topic.
Trudy Smith, adolescent contraception.
So I'm going to share my screen. Can you all see it?
We may, yes.
Cool.
There we go, yes. Got it.
Got it. I'm trying to make you guys all smaller. Thank you very much for inviting me. I would like to receive all your invitations, because I know you have some very interesting topics. So I will ask them to send them all to me. And really, to start this by paying tribute to my friend, Professor Denny. She sparked my interest actually in gynae oncology, and she was a great mentor to me, and I'm incredibly sad at her loss. And she certainly did a lot for women's health in South Africa, and particularly for cervical cancer and women in general. So let's start with a few articles that have been around in the newspapers. And if you have a look, it was very prominent during COVID. And in fact, in Gauteng alone, there were more than 23,000 teenage pregnancies in that 1 year, from April 2020 to March 2021. And there were 2,976 babies born to girls between the age of 10 and 19. And 934 babies to young girls between 10 and 14. So that's an incredible amount. But also, if you look in the Cape Times, there was a recent article at the end of last year, and basically, essentially nearly 4,000 children, they called them children, aged between 10 and 19, delivered babies in Cape. Within the first 5 months of teenage pregnancies in the Cape area. So the Hearst series was a group of researchers from the South African Medical Council, and what they looked at access, use, and perceptions of contraceptive services amongst adolescent girls and young women in South Africa. And what they did was they evaluated the HIV prevention program and contraception in these young women. And they looked at women between the ages of 15 and 24. And they looked in 6 provinces and districts. And they did a cross-sectional household survey. And interestingly enough, in the 25 to 24 year age group, 68% of these young women had already engaged in sexual intercourse. But even more interesting, what they found was that while they had had sex, basically 53% had access to condoms, 65% had access to other methods of contraception. Yet very few women actually used these contraceptions. Only 39% used another method of contraception besides a condom, and only 37% of young girls used a condom plus another method of contraception. And for me, that is really an important issue, because we should be obviously advocating dual protection. So not only adequate contraception, but also the use of condoms. And in fact, women who lived with HIV were much more likely to use contraception other than condoms, or to use both condoms and contraception compared to HIV negative young girls. And perhaps that's because maybe HIV positive young girls maybe had more access to information and access to healthcare. So although contraception use amongst these women was very low, what we find is that they were offered very few choices in their contraceptive method. And the method at public health facilities were very limited, with limited explanation of their side effects and mechanisms of action, compared to, for instance, in older women who perhaps are much more informed. And of course, who's left literally holding the baby? Clearly, it is the girl child or the woman who is left holding the baby. And we know that there are consequences to adolescent pregnancies. So let's talk a little bit about sex. So we all think our children aren't having sex. Yeah, believe me. Our children are all engaging in some form of activity, or a lot of them are. And in fact, if you look at the South African data, you know, that's why around the world, most HPV vaccinations in adolescents, which coincidentally should be gender neutral now, exist before the age of 14, because we know that from 14 years of age, there's a rapid increase in sexual experimentation and sexual debut in adolescents. And if you look at this data, it's quite interesting that the majority of young girls, whether cohort sexual or voluntary sexual intercourse, will occur with partners 1 to 4 years older than them. We always believed that adolescents were having sex with much older men, but not necessarily. The vast majority, in fact, are between 1 and 4 years older than themselves. So what does the Child Act say? So the Child Healthcare Act, which was promulgated, the 4th edition, on the 1st of June 2010, says that children should have access to contraception. And we must prevent sexually active children from contracting STIs or falling pregnant. And no person may refuse to sell or give condoms or contraception to a child over the age of 12. And in fact, persons who disregard this provision are guilty of an offense and can be fined or imprisoned for 10 years. Or be given both a fine and a term of imprisonment together. So if a child comes to us at the age of 13 requesting contraception, or even at the age of 12, we should be giving such a person contraception. The contraception may be provided to the child on request of the child without consent of a parent or caregiver, and they are fully entitled to confidentiality. But the healthcare professional is to report cases of physical or sexual abuse. So if a girl under the age of 16 is pregnant as a result of having sexual intercourse with a male who is more than 2 years older than her, the doctor is duty bound to report it to the police. So it becomes really difficult in your practice to really navigate this. But I think it's important that I feel really important that we need to be sympathetic, we need to listen, and we need to hear adolescents and be sure that they are safe, they are making the right decisions, and that we will guide them and help them rather than judge them. I think our biggest problem as older persons is to judge, and we should have no judgment.
Trudy,
and what do we put? Yes.
Trudy, there's a question here. What happens if the girl under 16, as in your previous slide over there, refuses you permission to report to the authorities? In other words, she says, I would rather have you not report this to any authorities. Are you obliged to do it and disregard her wishes, or do you have to
I
acquiesce?
think that's where ethics comes into play, and you need to guide her and say, I mean, obviously, if she's coming to you in all confidence, and I think you need to be sure that she is safe, she's not coerced, she's in a safe environment, because she might be, it's the same as abuse of women. If she is begging you because she might be unsafe, then you need to take that into consideration and possibly involve a social worker, etc. So it does obviously make it very difficult, but I think it also does not allow you to disregard her contraceptive wishes. Because you're making her even more unsafe by saying, no, sorry for you, I'm not giving you contraception because you're having sex with somebody who's 20.
No. What I'm saying is that I had a woman this week. She was 16, and she was coerced by her older boss, who was about 56, to having intimacy, having sex. And the contraception isn't the problem. The problem is she didn't want me to report this to the authorities. She said she'd lose her job. She was 16 and had a job. And she says then the whole family falls apart because then they don't eat. So I was on the horns of a dilemma.
You are on the horns of a dilemma, but you're on the horns of a dilemma that requires you to give her the tools to access care and help. Do you understand? So there are many interventions that you can do. You can give her the number for power, for people against women abuse. You need to try and convince her there are other jobs, but you can't change her social circumstances. All you can do is empathize and give her the power, and hear her and give her the power to actually be able to change it. Okay. That's my belief. And obviously, when you take into consideration contraception within an adolescent, you have to take into consideration their physical development, their cognitive and social development, emotional and moral development, because decision-making that affects an adolescent is quite different to an older woman. And adolescents, we all know, tend to be influenced by emotion rather than reason. Often an adolescent will say, well, my friend said she had the Kylina inserted and it was like frick, so there is no ways she's going to have that done. So, it's about listening, hearing, speaking, and really taking into consideration the whole picture of this adolescent and time. You can't do this in a 2-minute consultation. It needs time. And we all know the consequences. The consequences of a teenage pregnancy are really dire. And we know that, for instance, the highest number of teenage pregnancies occurs in the developing world. They have a much higher cesarean section rate. They have lower educational achievements as well as social opportunities. It increases suicide and homicide within the household. And I think that is important to think about. And obviously, there's an increase in stillbirth. And we know that children who have children beget more children. So often your mom was a teenager, you tend to be a teenager, and you never get yourself out of the cycle of poverty, perhaps, or educational achievement that you really deserve. So that's what you need to take into consideration when you're giving an adolescent contraception. So obviously we can decrease adolescent pregnancies by preventing early marriage, preventing early pregnancy through sex education and increasing education opportunities. I don't know if you saw many years ago when they first introduced, I don't know what that subject in school is now called, It's got a name.
Sex
I forget.
education.
LO.
Sex
LO,
education.
life orientation, yes.
Oh.
When they first introduced life orientation many years ago, somebody wrote an article in the newspaper about how we shouldn't be giving our adolescents beds to have sex because we're giving them sex education. And in fact, a very interesting article came out of Holland where they showed that if you introduce sex education early into a child's education, and we're not talking just about contraception and sex, we're talking about adequate pleasuring, lovemaking, sensitivity, having the other person's needs met, etc. And what they found is it actually decreased the amount of, wham, bam, thank you, ma'am, sex that was happening in adolescence compared to they really wanted to take it seriously, discuss it with their partner, etc. So education really does help. It also can be supported by economic and obviously social programs. And we need to really know and take cognizance that in our country, unfortunately, coerced sex is a huge problem. Like you said, it is a very huge problem. And a lot of adolescents start resorting to unsafe abortion practices. They also tend not to attend perinatal care. They also tend to be unbooked, and those children tend to have malnutrition, etc., when they're born. So it really is a problem. But for me, even more of a big, yeah.
So there's a question here, but I think you can finish and then we can ask it.
Yeah, have you ever looked at, I don't know, the Western Cape is better than Gauteng, but contraceptive clinics are only open during the day, and they're usually only open during school hours, which makes it really difficult for an adolescent to access contraception. So there's a lot of barriers. There's obviously social and cultural taboos, there's legal restrictions, and perhaps the one thing is healthcare attitudes and healthcare systems. We really need to assure confidentiality. If I get an adolescent come to my rooms with her mother, I turf the mother out. I tell the mother that her daughter is old enough to come and discuss things with me, and that the mom must stay outside because she's not going to talk about stuff if the mother's sitting there. And so I ask permission and I say, your mom can come in when you want her to come in. And I think you have to empower them, and you have to let them know that you are not going to disclose health information to their caregivers, and that they are assured confidentiality. And like I said, we need flexible times of our contraceptive clinics, and we need appropriate age visual aids. I mean, fortunately now TikTok, all of those things are important from a contraceptive perspective. We all know this, that obviously withdrawal and ads are no good, and we need to think about long-acting reversible contraceptives in adolescents. So if you look at contraceptive coverage and methods in the government sector, and they did this household survey, and most women had heard of injectables, and they take injectables and oral contraceptives, but very, very few knew about, for instance, emergency contraception, IUDs, sterilization. Obviously, that's not going to fall into adolescence, but, the injectable contraceptive in the government sector was the one that everybody knew about, everybody had access to, and the others are really ignored within the government sector.
Trudy?
So I think, yes.
I was just going to say, I've forgotten what I was going to say, Steve. Oh, we'll come back to it.
Okay, maybe we should ask a question while we have sort of stopped. Just a question from Ngunza Kamba about after reporting statutory rape, who will conduct the follow-up to make sure the case is processed in these busy institutions? Is it fair to refer the case to the parents, caregivers? And yeah, so that's really just the question.
I think I think that, if you're going to report a case, you need to involve a social worker. And, it's incredibly difficult for you to follow up. Generally, it will come back to you. But obviously, you need to also report it with the consent of the person that you're reporting it, like we said. So, yes, it's very difficult.
And there's another question,
Yeah.
a confidential question from Habib. He says, we had a recent webinar with Trudy de Villiers, and it was noted that Depo-Provera should be phased out because of effect on bone mineral density in the long-term use. What is your comment on this? Asks Habib.
Yeah, I'm coming to that one.
Oh, thank you.
Pleasure. So for me, the advantage of a LARC in an adolescent is it doesn't rely on user adherence for effectiveness. So I'll show you some data that the average adolescent misses 2.4 oral contraceptives a month. And the discontinuation of a LARC method generally requires consultation with a medical provider, and that gives you another point of additional counseling and discussion regarding its effects and the replacement thereof. And obviously, it also increases longer use without repeat visits. So here in Gauteng, if you go to a contraceptive government clinic, you only get one packet a month. I mean, that's ridiculous. You have to come back every month, take a day of school in order to get your contraceptive. And you have to come every 3 months for your Depo-Provera. Whereas if you use a much longer acting reversible contraceptive, then it's discreet. Nobody needs to know about it, and it affords you the opportunity of having the discussion of what to use.
I think the medical aids also. Sorry, I think on the medical aids, I think there's also, someone was complaining about that as well, is getting a repeat is also like on a monthly basis, and that also at that level is a bit of a challenge, to be honest.
I mean, why do I have to go to the chemist every month to get my packet of pills? Why can't I be issued 3 packets?
Yeah,
I find it very irritating, and why do contraceptives come out of medical savings?
Yeah, it's ridiculous, actually.
I mean, that is absolutely ridiculous. Why do vaccinations come out of medical savings? Nobody's going to pay 2,000 Rand for a vaccination out of their medical savings. These are preventative things. They should not be in medical savings. I mean, it saves the medical aid millions by not having a pregnant woman.
Yeah.
So the myths that a lot of adolescents have is that you need to have a pelvic examination prior to initiating contraception. They also think, everybody thinks they have to take a break from an oral contraceptive every few years. The myth on oral contraceptives and IUDs affecting fertility are a big problem. Many, many people think you can't put an IUD in an adolescent or a nulliparous woman. And in fact, you can put an IUCD in most people, provided they're not tiny. An IUCD can increase the risk of ectopic. We know that's no longer holds true. And an IUCDs do not have any non-contraceptive benefits. And we know that they absolutely do have non-contraceptive benefits. And there's still this myth about COCs and breast cancer, that everybody's going to get a breast cancer. Spelling. So let's start on our LARCs, our long-acting. So what about the progesterone-only injectables? First of all, it's a WHO category 2. So in other words, you can literally use it in anybody. In most people with medical conditions, it is safe to use. It is highly effective. Obviously, compliance is excellent. It's not coitally related. Its use is very private, and it's available for free. And there's no doubt that an injectable reduces dysmenorrhea, premenstrual syndrome, heavy menstrual bleeding. There's even data that being on an injectable decreases your incidence of fibroids. And I don't know if anybody knows, do you know anemia in adolescence decreases your IQ by 10 points? Isn't that amazing? 10 points. Sure. It leads to loss of concentration, missing school, etc. So for me, I think that That's also quite interesting. It is one of the few hormones that can be reliably used with liver enzyme drugs, inducing drugs. So if you're on ARVs, if you're on anti-epileptics, etc., you can use Depo-Provera. But there is disadvantages to it. So the unscheduled bleeding, certainly. The delay in fertility can be up to a year, and there's no doubt that it causes weight gain. And adolescents who experience more than 5% of weight gain after 6 months of Depo use are at continued use of risk of excessive weight gain. And here's the thing, is it can be associated with reversible bone mineral density loss. So we do not like the use of Depo-Provera in adolescents or in premenopausal women because of its effect on bone. It is a problem. Whereas, for instance, the implants are not and do not have an effect on bone. The younger woman, less than 18, the advantage of Depo, however, despite the bone mineral risk, generally outweighs the theoretic safety concerns regarding fracture risk, because we're hoping that also these adolescents are going to be much more active, they're going to increase their bone mineral density, etc. But we need to counsel them that they should be doing weight-bearing exercise, avoid alcohol, caffeine, and smoking. And in a recent randomized controlled trial, they did not find an increased risk of HIV acquisition amongst the use of Depo-Provera. And also, if you look at all the data on Noesterate and Depo-Provera, do you know there is no data on Noesterate, the 2-monthly injectable? We just extrapolate everything to the 2-monthly from the Depo-Provera. And I think that's really interesting that, in fact, there's very little long-term data on the Noesterate. But yes, Depo-Provera and bone mineral density is a problem. The NuvaRing. So is the NuvaRing truly a lock? Yes and no. So the advantage of a NuvaRing, it's obviously not available in the government sector, but the NuvaRing is a low-dose combined hormonal contraceptive. It stays in for 3 weeks and then 1 week out if you want a period. If you don't want a period, you take it out and put a new one in. What is quite interesting on the NuvaRing is that it gives you excellent cycle control. So in young girls, compared to oral contraceptives I'm talking about, so in young girls who have poor cycle control, the NuvaRing is actually an excellent choice. And now you can get a contraceptive ring app. It's called My Ring, very odd name. But if you use that app, it'll remind you when to take your NuvaRing out and change it. The contraindications, however, to a NuvaRing are the same for combined oral contraceptives. And unlike hormone replacement therapy, everybody thinks in hormone replacement therapy, your venous thrombosis risk is less in transdermal, but in the NuvaRing and in the Evra patch, in fact, the venous thrombosis risk is higher than oral contraceptives. Isn't that interesting? 2 times more than first-generation progestogens. So I don't think you must think that by using a NuvaRing, you're going to decrease your thrombotic risk. You're not. And certainly, liver disease, migraines with aura, diabetes and vascular disease, or undiagnosed bleeding, all the same for the other combined oral contraceptives, the contraindications are there. We said that the advantage, though, from these LARCs is that the potential to be controlled by the person. It avoids the gastrointestinal absorption. Vomiting and diarrhea is not a problem. And it's got a very stable PK. So I think it is underutilized, and it's something that we often forget and we need to think about in adolescence. What about the Implanon? I'm sure you're all aware of the new place where the Implanon is inserted. It's a subdermal lock. It's highly effective. It's changed every 3 years. It's quickly reversible compared to the Depo-Provera, and it has very few side effects except for the irregular bleeding, and it has absolutely no effect on bone mineral density. But of course, we've had incidences of poor insertion, of it being lost up the vascular bundle, of poor training in its insertion, which unfortunately has led to less use. I think it's used much more frequently up in the Western Cape than it is used in Gauteng. The bleeding pattern during the first 3 months is predictive of future bleeding. It's unlike the Mirena. If you put in a Mirena, you must tell them they're going to bleed for up to 6 months. If you tell them that, then they won't be disappointed if they are still bleeding through those 6 months. And then it'll settle down. Whereas in the Implanon, that bleeding unfortunately continues. And we can have a whole discussion on how to stop that bleeding. IUDs. IUDs are really underutilized in adolescents. Obviously, there's the Mirena and the Kylena. The Mirena might be more difficult to insert than the Kylena. The Kylena is smaller and much easier to insert. And as we know now, the Mirena is effective for 8 years and the Kylena for 5. But the advantage in the copper T is that it's much cheaper and it lasts for 10 years. The problem is the heavy menstrual bleeding that these young girls can get. And they can obviously, if they've started already with heavy menstrual bleeding, it becomes a problem and you wouldn't think about the copper IUD. Another thing we often forget about is postpartum contraception. Yes.
Sorry, Trudy. Can we just go back very quickly to the Kylena?
Yes.
It's very popular. It's a wonderful thing. Now, it's definitely 5 years. It hasn't been extended as the Mirena has. If you have a woman under 20, which would you recommend, or doesn't it matter? And sometimes, do you have to use Mirena if the young women do have heavy bleeding, or is Kylena also, what is the word, licensed to use, licensed for indication for heavy bleeding?
So for heavy menstrual bleeding, a Mirena is licensed, a Kylena is not.
Right.
In young girls who have heavy, painful periods with anemia, I would rather use a Mirena than a Kylena. But then it depends on the young girl, the size of her uterus. Remember, the Kylena is smaller than the Mirena, and it is more easily to insert in an adolescent compared to a Mirena. But I often use a Mirena because it also lasts for 8 years.
Yeah.
And so that gives you the better added advantage compared to the Kylena, which is 5 years.
Wonderful. Thank you.
So just from my
and
perspective,
just a lot of people think, oh, but I put the Kylena in 5 years ago. Does that one still last 8 years? And the answer is yes.
So what?
The Kylena lasts 8 years.
No, Mirena. You
I mean, the Mirena. So you put the Mirena in a patient 5 years ago, and they come to you and they say, I've come for my change of Mirena. And you say, no, dear. It now lasts 8 years.
Yeah.
Okay, so it's licensed for 8 years now.
Well, in America, but technically in this country not. But I can tell you right now that if it's licensed for 8 years in America, it's licensed for 8 years in my office as well.
Okay.
It's licensed for 8 years in the UK as well.
Okay,
so it works
but
for
not
8 years.
for hormone replacement therapy, hey? For hormone replacement therapy, it's still 5 years.
Okay. Yeah, so it's
really?
sort of as a, what do they call it? Opposition treatment. But I just want to ask you guys, just the Kylena. So who would be your ideal patient that you're going to be offering your Kylena to?
So my Kylena is to a young girl whose periods are normal. They're not heavy. And I would counsel her that she would probably still have her periods. Many of them come and they say they don't want a period. Then you must rather consider the Mirena. But I use the Kylena a lot in an adolescent. But like we were saying, in somebody with really heavy bleeding, I would probably use a Mirena before a Kylena.
Thank you.
Okay. Great.
I just want to bring something up about postpartum contraception. And the thing with postpartum contraception in an adolescent is this is really the time that somebody is most likely to access a healthcare facility. And postpartum women are often unlikely to use contraception, and they are vulnerable for future unintended pregnancies. So I would urge that you consider the insertion of a postpartum IUCD. It really has no effect on the amount of breast milk. It can be safe to use in HIV positive patients. You can put it in immediately post-delivery of the placenta. You have a slight increase in expulsion, but it's an excellent time to counsel and for those adolescents to access contraception. And it gives them a long-acting contraceptive immediately. So either at Caesar or even at vaginal delivery.
Yeah, I can understand after a miscarriage or a termination abortion having an IUCD. But the problem is, if you're going to have a cesarean section and people say, well, let's just pop in a Mirena after a cesarean section, that's off use. Off-label use. Would you?
But the contraception is not off-label use. I used to look. I don't deliver babies anymore, but I often inserted
a Mirena.
I often inserted a Mirena at the time of cesarean section.
Yeah, but that's off-label use. If you read, and I did read,
it is off-label use.
It's off-label use. It is.
Oh, there's plenty of off-label use of many things, and you have to counsel them that it's off-label use.
Yeah, but if you get into medical legal problems, the judge and the lawyers don't worry about that you've been counseling. They worry about this as off-label use and against the directions, is what I'm saying.
So you're saying you should wait until 6 weeks and then put it in?
No, your incidence of perforation is much higher at 6 weeks.
So when would you, okay.
Well, also, yeah. But I think we're getting slightly off piste, Joe. You better carry on. Yeah.
Okay, so now let's look at contraceptive use in the private sector. So if you look in the private sector and you look at the contraceptives that are issued and sold in the private sector, the vast majority are oral combined contraceptives. There are very few LARCs that are used in the private sector. And in fact, oral contraceptives and emergency contraception is your commonest use in the private sector. I find it quite fascinating that there's a big dichotomy between the two. So what about oral contraceptives in an adolescent? So peak use has been shown to be 18 to 24-year-olds. The average adolescent misses 2.7 pills per cycle. And the discontinuation rate of more than 50% during the first 6 months of use. And this is usually attributed either to the home environment. So often adolescents, parents are divorced, then they're with one family, with the dad, and then with the mother, and then you've got to try and hide your contraceptives, and it can present a really big problem, for instance, in storage and remembering. If the parent is on board with the contraceptive, I often tell the adolescent, the one thing most people never forget to do, and that's brush your teeth. And I say to them, take the contraceptive, attach the contraceptive with an elastic band to your toothbrush, and then you won't forget it. But, when you're trying to hide your contraceptives, it becomes a problem. So there's many health benefits to using a combined oral contraceptive in an adolescent. It decreases dysmenorrhea, endometriosis, their acne gets better, their premenstrual syndrome and premenstrual dysphoric syndrome gets better. Obviously, if you have PCOS, it's better, and your dysfunctional uterine bleeding is better. So there are certainly added benefits to oral contraceptive use. The failure rates, however, in real life users are really attributed to non-compliance. And in fact, the 24/4 regime shows much more reduced ovarian activity and improved efficacy compared to the 21/7. So if you miss a pill in the 24/4, you're less likely to fall pregnant than if you miss a pill in the 21/7 regime. But what's quite interesting is if you look at NOMAC versus with E2, in other words, Zoli, and you compared it to levonorgestrel, the NOMAC has a long half-life, And in fact, if you miss 2 pills, you're still more likely to be protected. So for me, the use, for instance, of Zoli in an adolescent, it's not going to make their skin better, but from a contraceptive protection is far better because of the long half-life of the NOMAC, and because if they miss a pill, they're less likely to fall pregnant compared to other oral contraceptives. So for me, that's an attractive OC pill to use in an adolescent. Emergency contraception, unfortunately,
Sorry, there's another question come through over here. If price was, it says here, if price was no consideration, what
Yes.
would be your first choice in a young girl for a combined oral contraceptive pill?
I'd use Zoli. But you see, again, it depends. Does she have acne? Does she?
Well, this is the question. This is just a question off panel, but
you know, it's not a one size fits all. I find Clara incredibly difficult in an adolescent. Because they often miss pills. But, you know, you have to counsel patients, for instance, if you use Zoli, that they might become amenorrheic. I don't know if you've noticed, nearly 60% of patients can be amenorrheic. And then they're terrified because they think they're pregnant. And then you have to counsel them.
If you tell them beforehand, they accept it and they love it. But it's also safe in young girls, is it not?
It's absolutely safe in young girls. And Clara is a good one to use, for instance, in young girls who get menstrual migraines, because you've only got 2 placebos.
Yeah.
So, you know, there's lots of little nuances in contraception. It's about what each person has and what's wrong with them. Unfortunately, emergency contraceptives are absolutely fantastic, but it will not make women less likely to use effective contraception. So, you know, it would be ideal if you could say to a young girl, here's your emergency contraceptive, but what are we going to use long term? And perhaps, you know, if she comes to you and needs emergency contraception, perhaps the insertion of an IUD will, at that time, will give her long-acting reversible contraceptives. So, you know, you need to, you know, most women who access emergency contraception will go to the chemist to get their emergency contraception. And then nobody is following up on what they're going to do long term. But, you know, I'm grateful that there is emergency contraceptives. So I think in conclusion, we have to say that adolescents face multiple barriers, particularly at accessing contraception. And I think particularly many healthcare professionals can be judgmental, and we need to not be judgmental. And long-acting reversible contraceptive methods are really and should be recommended and should be first line. There was the Contraceptive Choice Program that was in the United Kingdom. It was a huge trial they did. And the thing that they found was when you gave the person time and you discussed contraceptives with them and you gave them the pros and cons, they in fact were much more likely to choose a long-acting reversible compared to an oral contraceptive, because, you know, it's a very easy, I need contraception, here's a prescription, start it with your next period, you know, off you go. And then I think we need to also take consideration of the Depo-Provera and bone mineral density when we use it, particularly in our very young adolescents. And at all times, we must encourage the use of barrier contraception. You know, even in my own children, I tell them, you know, no glove, no love. That's the way it goes. You must use a condom at all times. So, you know, if we can just empower adolescents, give them space and time, I think we could decrease the incidence of teenage pregnancies. I really, really do. And allow, you know, women who are being coerced into sexual intercourse need to be safe. And we need to make sure they're safe and allow them the space to be safe. This was a great article to read, Contraception in the Adolescents, if anybody wants to. It's a nice review article that came out of Canada. And I think that's all I have for you.
Trudy, that's wonderful. We've got a whole lot of questions. Just before Steve asked the questions, you know, tomorrow Parliament's opening next door to us over here at the CTICC. And if they were short of a Minister of Health, because they're casting around who's going to be Minister. And if they ask me to be Minister of Health, the very first thing I do is make contraceptive clinics.
I thought you'd make Trudy Minister of Health.
That too, Mistress of Health. No, I'd open contraceptive clinics after hours and also on weekends, because it's an absolute craziness that schoolgirls and schoolboys, I suppose, but the girls and boys aren't able to access contraceptive advice and techniques during after hours times, because that's when they need it. Weekends, if nothing else, Steve.
Yeah, no, absolutely. I think that's a point that needs urgent attention. And I don't know if anyone was even lobbying for that. So
apparently in the Western Cape, there are some clinics after hours, but they should all be after hours. So contraceptive clinics should open from 4 in the afternoon, basically, until 9 o'clock at night, and then on weekends.
Of course,
no, it's
completely.
It's a very good idea.
Steve?
Yeah, we have quite a few questions. So the first one by your friend Habib Habib.
Habib,
also known as the anonymous attendee. It's easy to involve a social worker to take up the case in a public hospital sector, but what do you do in private, where that consultation is not free of charge?
I must say, in my hospital, we have a social worker at the Donald Gordon. I don't know if you have one at your hospital.
We actually do.
Do we?
Yeah, his name is Tommy.
Most hospitals have a social worker and you don't know about it.
Yeah.
Like me. Pete knows about the social worker. Is neuvering considered a lark? If so, then
strictly not actually, because a lark is more than a month. And is a neuvering more than a month? You know, because it's 3 weeks in and 1 week out. So
what about the patch? Should the patch also then not be considered a lark?
Well, a patch is once a week, so that's not a lark.
Okay. And then Moira Stein asks, are you happy for 8 years efficacy of Mirena, irrespective of age, 16 or 45 years old?
I'm very happy with 8 years, provided I'm not using it for HRT.
Okay. And then
I'm exceptionally happy.
And then your friend Habib, another question, can the Mirena be used as emergency contraception, and is there evidence for it?
Yes, it can.
Next.
And then again, and then Lionel, why so limited choice in the state sector regarding COCs? Who has influence on these applications?
It's all about money, Steve, isn't it?
It's about money. Look, COCs are available in the state. They all have funny names that I don't know anymore. And most of them, unfortunately, are high dose 30 micrograms. So the traditional Nordette, etc. Yeah. So I don't know what the names are. They are available, but again, the person has to come back once a month. You know. So, for instance, the lady who works for me, I just buy her 6 months supply.
Yeah, I don't know if anyone else is on the website tonight, or who wants to give a little bit more input into the state sector, because I mean that is.
We'd be delighted to hear the Minister of Health explain.
Yeah.
Just to get back to, there's 2 questions. The one question here is just to explain why a Mirena, when used for postmenopausal opposition, is only good for 5 years. Trudy, can you give us a short answer there? I know it's off piece again.
I think because we haven't got enough data to say that amount of progestogen will give you uterine protection against the amount of estrogen that you're using. So nobody has really looked at endometrial hyperplasia beyond 5 years of use in a Mirena with somebody on transdermal or oral estrogen.
Right.
And data, I have no doubt, will come. Because initially they used to say 3 years only for the Mirena and 5 years for for contraception, and now we know it's 5 years for the Mirena for HRT.
Yeah. And another question here, is there any way of getting around the abnormal bleeding issue with implanons because it is really a huge issue. And personally, I don't know who makes them, but I've taken out more than I put in because of the bleeding issue and the fact that the women don't like the abnormal bleeding. And in the olden days, when it was put in the biceps, it did used to wander around. Now, of course, as you say, it's been advised that you put it in the triceps area.
So I don't know if you
around the bleeding base.
what was that guy from Australia? I'll think of his name. But in any case, what the bleeding, why you bleed is because you get an unstable endometrium. You get crumbling of the endometrium. So there's a little bit of data, and I've tried it, and I've used it even in patients with a Mirena, is if you give them doxycycline, 100 milligrams BD for 10 days, it often stops the bleeding.
Okay, so that's a very good trick to use, and we can certainly
How
advise.
does that work, by the way? Sorry, I just.
So it stabilizes cyclic AMP in the endometrial. So basically you get crumbling. That's why you bleed all the time. And it stabilizes your endometrium. Remember, doxycycline can be used as an anti-malarial. It's used for many other things. So it's not used as from an antibiotic perspective. It has an effect on cyclic AMP, and it stabilizes the endometrium itself.
Wow. Okay.
You told us that before years ago, Trudy. I don't know if you remember telling us
I
that.
don't remember it.
No, I remember. I remember Trudy telling us that.
Fraser, Ian Fraser. Ian
Oh, you don't mean
Fraser.
Rolf?
The word.
Rolf Harris. No. I've just had a message here. Before I forget, I just want to put it in here that Karain's very kindly reminded me that there's a break for 3 weeks, and the next webinar is the 11th of July with Graham Howarth talking about HBCSA complaints. Well, I've got complaints about the HBCSA. I tried to log on to their ethical webinar tonight, and they were 30 minutes late. For 30 minutes, I was left hanging, waiting for the HBCSA ethical webinar, which eventually started 30 minutes late. Sorry, that's not, it's not Karain, it's Wendy. She just said it's not Karain, it's Wendy. So that's Wendy that's told us. Steve, other questions?
There is, doxycycline for how long? It's 10 days, you say. Someone that's at least
PD for 10 days, you said, Trudy.
Yeah. Okay. Yeah, well, that's it. I mean, thanks. It's always wonderful to have you, Trudy. I mean, I personally learn a lot as well. Yeah. And, I think we are probably due another, webinar on contraception. It's, there's a lot to know.
What about contraception in the elderly woman? We know there's no contraceptive in men, so that's off the menu.
Well,
what about
pity, hey?
Yeah.
Well, I mean, it's just condoms, but I mean, you know what men are like. Men are disgusting. They disgust me, quite frankly. But in older women, I don't know what.
For me, it's first of all, I think a Mirena is a very attractive contraceptive in a perimenopausal woman because it sorts out their perimenopausal bleeding, and you can use it when they become menopausal if you need to use HRT. So, for me, it's very attractive to use a Mirena in a perimenopausal older woman. And Depo-Provera is a problem in those women, particularly more so because they've got no time to recover their bones. So don't do a Depo-Provera in that perimenopausal woman. Bones are a big problem.
Yeah. Now, just about bones in perimenopausal women. I've got an American woman over here, and she lives in South Africa, and she's almost perimenopausal. She's a black woman. She's highly, highly motivated for physical activity, and she doesn't have a small BMI. I spoke to her about this very real problem of BMD, and she said, well, she's happy to carry on. Is it acceptable in a woman with low risk for osteoporosis and osteopenia to carry on the BMD, Trudy?
What to carry with Depo?
Yeah.
Well, I mean, obviously that's a personal choice, but the thing is that we've got good fracture data now coming out of black women in Africa, and we underestimate the amount of osteoporosis. We really underestimate the amount of osteoporosis. And if you look, there was excellent data out of Durban in terms of osteoporosis in black women, and unfortunately, they're adopting a terrible Western diet. And so I really think, obviously, it's the choice of the patient. And if they're happy on the Depo-Provera, that's up to them, but you have to counsel them about bone mineral density.
Okay. We're running out of time, but there's just 2 more questions. I'll take the first question, Steve. It's from Joyce Mukewa from Zimbabwe. And she says to you, it's not a question, it's a comment. She loves your presentation, Trudy, and she hopes you give more. And the next one perhaps would then be on contraceptive choices for the perimenopausal woman. When do you start? What do you use? And when do you stop? Steve, the last lady is the last question is from Kathy van der Westhuizen.
Yeah, so Kathy wants to know, is the doxy given as a treatment when they present with abnormal bleeding only, or can you give it at insertion, sort of as a prophylactic type option?
No, I don't think there's any data on prophylaxis. I would only give it as a treatment if it continues.
Okay.
But, you know, you have to counsel them that at least 3 months you'll get the irregular bleeding. Like I said, in the Implanon, if you're still bleeding after 3 months, you're more likely to continue bleeding. You know, so it is a problem. Bleeding is a problem with Implanon, but it's a fantastic contraceptive.
Well, that's why it's a contraceptive. You just bleed all the time. So, Trudy, it's been wonderful having you. I'm not saying anything negative at all about Implanon. I do, and thank you very much for your comments regarding Colleen and Morena, and also Clara. I'd like to especially thank then Bayer, our sponsor this evening. And as I said, we got a 3-week break now. We'll let you know when we start again. And then we have our old friend Graham Howarth, and he's going to be talking about, what did I say, Steve? About medical legal
SPCA complaints, which is an important topic.
Yep.
Yeah.
It's been wonderful, Steve. Would you like to thank
thanks again. Well, I think, again, just need to say, just a wonderful topic, a wonderful talk. And as always, Trudy, and we really appreciate your time and effort. It takes a lot of time to prepare these talks, and thank you so much. And well, thanks to Pete as well for the last few months. And we look forward to seeing you all in the new term, the third term.
Third season,
enjoy your holiday,
third season, Steve. And thanks again. It would be remiss for me not to say thanks, Steve, for the use of your mini bar when you were away.
Always.
Thanks a lot.
Thank you very much.
Thanks,
Have a beautiful evening, everybody.
All our delegates said logged on, safe home, take it easy, and I hope to see you in 3 weeks' time from now. Thanks very much.
Thank you very much.
Okay. Bye-bye.
Thank you so much, Doctor.